Thank you very much to those of you who have joined us in this room, but the many of you are joining us on Zoom. Thank you for making the time today to join us in this THF dialogue. I think many of you are familiar with the HEAD Foundation, but let me spend a quick couple of minutes to share a bit about us, the work that we do, and why talks like this are so important for us. The HEAD Foundation is a philanthropic organization established and based in Singapore about a decade ago that looks to use its resources to work towards the improvement of both healthcare and education for development in Asia, specifically in developing Southeast Asia. We work on education programs and projects, and we look at the healthcare aspect of what we can do to help our region as it develops, as it prospers, that it will be an equitable form of development, an accessible form of quality education, quality healthcare for everyone. Talks like the ones that we're organizing today are an opportunity for us as part of the THF dialogue to invite leading thinkers and thought leaders to share their perspectives on issues that are close to our heart and we know close to many of yours. So today, we're truly honored to have as our speaker, Dr. Tan Min Han. Dr. Tan is an oncologist and a clinical cancer geneticist by training. Today, he's the founding CEO and medical director of Lucence Health. Lucence Health delivers liquid biopsies for cancer detection and is the first Asian headquartered healthcare organization to receive US medical national insurance approval. Today, Dr. Tan will be talking about ending cancer as we know it in Southeast Asia. I hope you enjoy his talk, and feel free, especially for those of you who are joining us online, put your questions, your comments, your thoughts into the Zoom platform, the Q&A or the chat function, and I'll be happy to read your questions later as we move to the Q&A portion of today's talk. So ladies and gentlemen, please join me in inviting Dr. Tan to share his perspectives on today's talk, Ending Cancer as We Know It in Southeast Asia. Dr. Tan, please.
Thank you very much, Vignesh, for the very kind introduction. So I have the pleasure to present today on a topic very close to my heart. It's really about ending cancer as we know it in this region. And I emphasize that this is about not eliminating cancer, because this is always going to be with us as a very ancient scourge, but it is about changing how humanity interacts with cancer, that this was seen as a death sentence. It's still the scariest word in the English language. But we hope that with technology, with funding, that this will become not a death sentence, but something that we can live with, that we can manage. And in a world where we can detect this earlier and earlier than ever, that this will be the most treatable, that this will be treatable with earlier cancer detection. So this is my background, my story. Let me just stand this. Is that okay? It's like I'm speaking to a live stream and also to an audience, right? But all good. So this is my background. In my past life, I was a medical oncologist. I used to head the urologic cancer unit at the National Cancer Center just down the road. I saw patients with metastatic prostate, kidney, bladder cancers, as well as some lung cancers, and patients at high risk for disease with strong family histories, or young patients with cancer. I've also led a research lab, a research team at 𝗙𝗚, which is Singapore's largest public sector research arm, where I focused very much on liquid biopsy or advanced blood test research. Lucence is very much the result of a lot of those inventions we had developed first in the public sector, and then we spun out into a company which now delivers tests all across the United States for American cancer patients, as well as to this region, Southeast Asia, for patients in this area. But I guess what really influenced me was an early experience I had. I used to lead the Singapore breast cancer screening program. where this oversaw about a total of 29,000 women who attended screening, but there were also over 100,000 women who, did not, right? And it was in the understanding of how an imperfect test, mammograms, a test which has a low sensitivity, a low specificity, that also means it has both false positives and false negatives, where only 1 in 20 people who are highlighted as positive, 1 in 20 women actually have, in a positive call, they actually have breast cancer. So how did a screening test like that enter, the healthcare system, right? And that was a very deep understanding of how resources, how the healthcare system manage this. So I think that's really the background to my understanding of the challenge of cancer care. So I want to begin by saying that there are 19 million new cancer cases annually worldwide. That's 1 new case every 2 seconds. 50% present in the late stage. There are 10 million deaths a year. 60% of this burden of human suffering is in Asia. And I think that's firstly important to recognize that Asia bears a huge proportion of this suffering, and we want to see what is, overcoming this is going to be key. The next thing is that cancer is also a disease of the elderly. Yes, we are seeing cancer appear and in the younger generation, and people, it's more evident, whether this is environment, whether it's something else, genetics, that part is important to understand, but overwhelmingly, it's a disease of the old. With Asia's aging, today, we are going to see more cancer, right? And it used to be 1 in 4. Now, it is going to be 1 in 3. And I often sometimes say at meetings, look to the person on your left, look to the person on your right, one person, one of the 3 will get cancer, and then we are going to trend towards the Western profiles, which is 1 in 2. So I think we are looking at a society throughout Asia where this is becoming a more and more important problem. In Southeast Asia, screening resources are extremely limited, and this is because of the population-wide needs. And even in Singapore, which has a high GDP, screening resources focus primarily on breast, colorectal, and cervical cancer, right? And of these 3, breast was funded relatively recently, somewhere in 2018. I would say this, screening resources are uneven throughout the region. We are looking at a major burden. We are looking at resources that are it's important to start discussing about payers, but because we are looking at a truly huge burden for Asia over the next 30 years. And this model is, it scares me even to write it down. It's $10 trillion over the next 30 years, representing a major, drag on the region's development. Southeast Asia's share of this burden is $2 trillion. Also unevenly spread throughout the countries here. But I think we are looking at a challenge and also an opportunity to help reduce this, because if we are able to understand this is the burden that society is going to bear, what are the interventions needed? What are the funding policies required, across both the public and private environment to help improve and reduce this burden so that society can continue its economic growth to spread out these challenges in a more equitable way. And I want to say these numbers are not abstract, they translate into the human experience, right? Should I go to work or should I stay at home to bring my mom to her chemotherapy? Should I, actually choose to treat my parents, with a specific drug, or do I, choose not to? And, in societies with access to more facilities, these are going to see cancer very differently from societies without. And the end of life care is for those who have gone through it. And I've been touched by cancer, my family has been touched by cancer. End of life care is one of the most incredibly difficult experiences in caring for, the elderly or the people who are, have mobility disorder difficulty. So all this is going to disproportionately affect Asia. It's going to disproportionately fall onto the poor, the people without the resources to deal with this. So these are important topics to talk about. So, and we all do our best to solve a little part of the problem. And the part which I have chosen for myself is that I want cancer to be detected as early and as accurately as possible to achieve the best possible outcomes when it is most treatable. A 1 centimeter tumor is going to be easier to treat than a 3 centimeter tumor. I think that part, is evident to, physicians, right? It's always going to be easier to deal with a problem early than late for cancer. So I want to now, having talked about the burden of society and the challenge ahead for cancer, I want to focus now on the next thing, which is the difficulties around cancer screening. 78% of cancer deaths today outside the 4 I've talked about, breast, colon, cervical cancers, these are in unscreened cancers. These are in cancers such as liver, gastric, pancreas, nasopharyngeal cancer, many others. There are over 100 types of cancer, and today we only have screening in Singapore. I use Singapore as an example for 3 of them. In the United States, it's 4. That includes, in the United States, lung cancer, for which for smokers, low-dose CT scans are recommended for smokers in the United States. But I want to say there are so many other types of cancers and these contribute the majority of the cancer burden that society is going to bear. This is just an example. First, I begin with lung cancer, which is the #1, the top cancer killer worldwide, right? Where many of these patients present late. That access to screening requires expensive equipment that in centralized facilities, difficult to set up, expensive to set up, with a low throughput compared to the needs. They involve radiation, extremely challenging for the community. And in Asia, what is actually relatively little known is that non-smoking Asian women, especially East Asian women, are at similar risk of death from lung cancer as for breast cancer. There's a very specific type of lung cancer in the region that disproportionately affects non-smoking Asian women. And I think there is, for many such patients, there is a very unfortunate stigma because everyone thinks this is smoking, but it is not. So I would say this is really the #1 problem. Just as another example, nasopharyngeal cancer. Globally, on a country basis, the 2 countries in the world with the highest per capita rates are Singapore and Malaysia. Some people find this surprising. Why not mainland China, where it is very common in the south? And this is actually a remarkable example of why the northern part of China actually has relatively low rates. And that actually means Singapore and Malaysia are the highest in the world on a per capita basis. To give another example of the burden, in Indonesia, this is the 4th most common cancer, right? And even in our region, in Sabah, Sarawak, we are looking at patients as young as 8 to 9 years old get nasopharyngeal cancer. But so very, very few patients present at the very earliest stage when something can be done about it. By the time this is, excuse me, sorry. By the time this is presents, it is often, at a fairly advanced stage. So these are just examples of Asian cancers common here that, so much can be done about. Leukemia, and this is something we often see in the news when there are appeals made, simply because it is just so expensive to care for a patient with leukemia. It can be in the hundreds of thousands of dollars. And what is truly heartbreaking is that many of these patients, we are talking about cure, right? It's not life prolonging. This is about cure. And just excuse me for a second, I'll just disable this. Yeah. So this is something where the societal burdens in terms of, are absolutely important to manage, because there is also no routine screening for leukemia. So I'm just giving examples where there are all these cancer types contributing to 78% of deaths. Now, we would hope that at least for breast, colon, cervical cancer, that there are opportunities to manage this better. But these traditional approaches are painful, they are invasive, right? They are challenging because you have to visit a central site. Just to give an example, right? Both mammograms and colonoscopies, they require, visits to expensive healthcare facilities. The throughput is low. The machines, are challenging to maintain. For colonoscopy, this requires, not just skilled staff, but it's an invasive procedure that takes the patient away from his or her life for a long period of time, right? Because there will need to be a process of bowel preparation, visit to the facility, recovery after anesthesia, and these are all challenging for any healthcare system. So 40% is, I'm just using that for mammograms, but in reality, I actually think the number is much, much lower, even in a system, that's fairly urban and centralized like Singapore, right? So I think many tests are available, but if they are not used, they are of no benefit to society. So I think what I'm describing here are all the problems ahead of us, all the burdens to society, and what is at least one solution to this system that, myself, many other systems, many other companies, many other academic organizations are working on. So President Joe Biden, when he was vice president, he launched something called the Cancer Moonshot, and the goal of this was to reduce cancer deaths by 50% over 25 years. So when he re-entered the White House, the vision of reducing deaths, of course, not only through better testing, but greater access and wider use of therapies, targeted therapies, multi-cancer early detection, or MCED for short. Such blood testing was seen as a pillar, an opportunity to detect cancer earlier when it was most curable. So I think this is the first and most important. So this is stated as a mission for the fighting cancer pulls together everyone, East and West, right? Because it's a common enemy for all societies. And so the direction to develop not just better diagnostics, better therapeutics, better access, this is a sort of a program to pull everyone together. This is an example of one foundation in the US that responded to this message. And I think it's very, very clear that MCED, or multi-cancer early detection blood testing, the goal is really that it's not just about the 4 cancers, it's about one blood test that can cover multiple other cancers. That these blood tests not only detect cancer, the multiple other cancers, they can identify vulnerabilities or mutations in the cancer that will allow for treatment to be used. So as an example of these targeted treatments, lung cancer today is a very different animal from 20 years ago, where today we are talking about survivals of 5 years in lung cancer, but 20 years ago, when I first graduated, it was essentially very, very few options. But today we are seeing a lot of hope for lung cancer. And finally, of course, the whole idea behind better technology is to save lives. So in my own hope here is really, as a company focusing on the development of incredibly sensitive blood testing, is that we want to make this a reality today, that one blood test, 20 cancers, and the idea is earlier detection of a cancer, in an accessible way, blood testing is much more accessible than visiting a central facility, that can achieve better outcomes. So today, as a company, both in the United States, we can access the furthest reaches of Michigan with mobile phlebotomy. Similarly, here in Asia, with the changes in healthcare, we are able to send mobile phlebotomists to the homes of people in Malaysia, in Thailand, everywhere, right? Because a blood test becomes much more accessible and usable to a broad range of people than people coming to a central facility. How do we do this? The key is in recognizing that cancer markers in blood today comprise two types of signals. The first is cancer mutations, because cancers do mutate, and these drive the behavior of the cancer to grow aggressively. I think there is a cutoff here, but it's actually virus. It actually says virus. The top few cancers in the world, whether it is cervical cancer or liver cancer or 𝗙𝗚PC, these are all viral-driven cancers. So it's important to recognize that detecting these viral signals in the right place can correlate well with earlier detection of cancer. So just as for cervical cancer, it's really about either physician or even self-testing of HPV, and this is routinely done in clinics everywhere in the world, or whether it's 𝗙𝗚PC or with the blood testing. 𝗙𝗚PC stands for nasopharyngeal cancer. We are looking at a signal in blood that can correlate at its earlier stages to cancer. So these fragments, these materials from the mutations, this is very much a DNA. These are DNA fragments which are shed from dead and dying cells in the body from the cancer. So if for a patient, say with a 2-centimeter tumor, as those cancer cells turn over, they release fragmented DNA into the blood, and these can be picked up by blood tests. And these are now the new markers that such blood testing can help to detect and pick up at the cancer's earliest stages. So in our work, we have focused very much on the initial detection of 10 cancers first, before expanding this to 20 cancers. And so we routinely today provide support to multiple hospitals in the region, both in the United States and in Asia, for treatment selection for late-stage cancer patients. So that's a proportion of the population that needs better treatments and better drugs. And that's really, really important application. I see that this technology is important to help solve the problems of the wider society. We are working on making sure this is going to detect several of these cancer mutations in blood at the earliest possible time. And so today, how do we look at these 10 critical cancers? How do we select them? Clearly, it's by three major considerations. Firstly, they must be common in the region. Secondly, they are certainly more common in Asia, and certainly cancers like liver, nasopharyngeal, bile duct, these are cancers that are common in the region. We certainly want to detect cancers for which that can be treated at their earliest possible stage. So I think these are the technologies that are coming to pass now. So in taking one step back, and I want to say, obviously, we are not the only company and the only institution. It's very important to highlight that as society moves forward into earlier cancer detection, both in the United States with the US Cancer Moonshot, and in Asia as we make these cancer control programs, front and center, there are two different schools of thought here, which I've represented here in this chart. The first is companies focusing, or organizations focusing more on Asia or the West. And this is quite natural because Asia has a very different cancer profile as compared to the West. We do see that even regionally, there are many different cancer types that do vary. For example, as mentioned, even in nasopharyngeal cancer, the north part of China, Japan, Korea has very different rates from the south. Melanoma is common in the West, but very rare in Asia. There are types of breast cancer in Africa that are much more common in Africa as compared to the rest of the world. And so I think we are seeing the fragmentation, and that's fine, because definitely we need local solutions for local problems. What is more of greater interest is the next step, which is really multiple cancers in one blood draw or one cancer. And why is this even an issue? I think this is a complicated question behind the difficulty of stakeholder reimbursement. Today, I think when we saw the challenges around COVID-19, in the early days of COVID, we saw the challenges of how regulators, including the FDA and its equivalents everywhere, together with the challenges of the payers, commonly government and private, the data behind multiple cancer detection is going to be a lot harder to put together as compared to single cancers. And you can imagine, right, the size of the studies, the difficulties. At the same time, I think there's a very strong argument for multi-cancers as compared to single, because if there are 100 types of cancer, you don't want to go for 100 different tests. And I think that part is also clear, which is from a patient perspective, it's important that we have something useful. But we must also consider that in any healthcare system, it's not really just about the patient. That is the center of everything. But we must recognize there are other parties here, other stakeholders, such as regulators, such as payers, and it is the conversations between these stakeholders that drive this question. Is a multi-cancer approach better in blood, or a single cancer approach, which tends to be easier for the regulator to handle? Yeah, so I think this is important, because you might get different results and different approaches in different countries, depending on the relationship between the clinicians, the regulators, the payers, and the patient. So I want to end today's talk. Southeast Asia is facing a cancer tsunami. It's not just a question of the burden of economic burden, but it's a real burden of human suffering, right? It's reflected in all the little challenges of life that we encounter throughout our existence. Detecting cancer when it is most treatable is key. It's always going to be easier to handle a 1 centimeter tumor than a 5 centimeter tumor. Always. Cancer early detection is a key to the Asian moonshot. And I think one very important thing is it is uncontroversial that the fight against cancer, it pulls people together. Medicine is the one thing, is the one profession that I can go to any society in the world. And, physicians share so much in common with each other. I don't think there's any other profession where so much in common, the values, right? The way things are done. And that conversation is so important to pull everyone together. And even in today's, fractured and fragmented world, we do see those conversations going on right now, even in cancer anti-cancer programs in both the United States and China. These continue, and these bring together people and in a common fight. So I think this is really, really key for us to invest in and to work towards a world where we can, end cancer as we know it. Yeah. All right. Thank you all very much.
Thank you. I too have to speak to the camera. Thank you very much, Dr. Tan. Ladies and gentlemen, I think now we'll move to the question and answer segment of today's discussion. But as we kick off the question and answer segment, we're very honored today to have joining us also a very distinguished physician in himself, Associate Professor Lim Chui Meng. He's a consultant at the Singapore General Hospital's Otolaryngology Department. I hope I did that correctly. I did ask him beforehand how do I pronounce it. So I'd like to invite Professor Lim and Dr. Tan to join us on stage And Dr. Lim can share some of his comments as we move to the Q&A segment. So yes, Dr. Lim, maybe you would like to share some of your perspectives on what you heard Dr. Tan share, and maybe how these implications in the work that you do every day in SGH.
All right, thank you so much, Vignesh. So yeah, so to be honest, I'm an ENT specialist. I'm a surgical oncologist. So the field that I'm particularly familiar with is hair and neck oncology. And I think what Dr. Tan mentioned earlier, one of that cancer that came out very prominently in our field is nose cancer, or what we know as medically called nasopharyngeal cancers. For those who are unfamiliar with this cancer doesn't, the nose is not the external nose, but we're referring to the back of the nose called the nasopharynx. And because of the hidden location, so to speak, by the time patient come to see us at diagnosis, typically they come with enlarged lymph glands in the neck. And that's when we do, as an ENT specialist, we do a scope and we say, hey, there is a tumor at the back of the nose. And the reason for that lymph node enlargement was because of the cancer in the primary site. So, but we know as surgeons and oncologists, when the patient come with lymph nodes in the neck, typically they are more in advanced stages. And I would say a ballpark figure, how we commonly see NPC presenting with lymph node in the neck is about 70%, about 2/3 of 70%. So I think on that note, certainly there are many initiatives, both endemic areas like Hong Kong, Singapore, as well as Southern China, where this cancer is highly endemic, where researchers, clinicians have focused on screening. So I think it comes on quite nicely with what Dr. Tan have mentioned. So I certainly think there is a role for screening for this particular cancer, NPCs. More in line with my work, where I follow up cancer patient, NPC patients after completing treatment. And because of the biology of this cancer, as what Dr. Tan mentioned, there is a virally driven cancer. And this virus is what we call the Epstein-Barr virus, or the EBV. So currently we are using both in our institution at NCC as well, we use this liquid biopsy technology that can detect fragments of this virus in the patient's blood. And we know that when the patients have detectable EBV virus in the blood after completing treatment, that usually is a poor sign, meaning that we are kind of anticipating whether there is some occult cancer lingering in the patient after treatment, or during our follow-up. So on that note, I think particularly not just in terms of primary prevention, but in terms of established cancer where patients have already completed definitive treatment, some of this technology that we know that is a very specific marker that we can use it to detect in cancer patients on follow-up will be helpful. So I would just attest to that, at least for the NPC in the NPC clinical care.
Thank you very much, Dr. Lim. Ladies and gentlemen, I think we have a number of questions coming in on the chat on Zoom, but also to the audience in the room. If you have any questions, just sort of raise your hand. There are a couple of mics. Please use the microphone when you're asking the question, because otherwise our friends who are joining us on Zoom won't be able to pick it up. I'll start with a question that came from one of our attendees online. And this is sort of a question that I'm also kind of curious about. Is this high occurrence of cancer a recent phenomenon, or is medical advances in medical sciences allowed us to realize that there are more cases?
I think it's really two things. One is the ascertainment bias, which is that it's certainly something we all know much more about. So that's clear cut. And the second is the change in our environment, where we have a very different exposure, both in terms of the food and water, as well as, of course, the air pollution that we are exposed to. In fact, air pollution, I think, is a major risk factor for cancer. These are the two quickly changing things. For genetics, as our genetics, that doesn't change so quickly. So that part is fairly stable. I hope that sort of answers the question, the environmental and the ascertainment. Yeah.
And I think the environmental is very concerning, because if you mention air pollution, most of the world's most polluted cities are in Asia. And that comes to a point that sort of got me thinking as you were sharing, Dr. Tan. You talk about the common viruses in Asia, but we are a very, very diverse population, possibly the most diverse continent in the world. So how do these common cancers, considering that very much the genetics across Asia can vary quite significantly, the ethnicities across the region. So how do we determine what are the most common cancers? And are there a lot of commonalities, and why would that be? Maybe I'll let you.
So if I understand you correct, your question, Vignesh, is that why is, given the diverse population in Asia, why is cancer remaining so common?
No, I think more, what are the common cancers, right? Because
Yep.
we did talk about the common cancers in Asia,
Yep.
but we are a very ethnically diverse continent. So are there really, why are these cancers common? Because we are very diverse, and many ethnicities in Asia are probably quite similar to ethnicities in the West.
Yep.
So why are these cancers still common in Asia?
So perhaps I will bring back again to 𝗙𝗊𝐶, because that's my view where I can give you more evidence from that perspective. So certainly, like what Dr. Tan mentioned, quite uniquely, 𝗙𝗊𝐶, although it's common in Chinese as a race, that we commonly see our patients with this cancer. But you look at in the literature, only the southern belt of China, like Guangzhou, the province, Hong Kong belt, etc., that these are the group of Chinese that typically develop 𝗙𝗊𝐶s. If you go further north, like in Beijing, Harbin, the northern belt of China, this cancer, I asked some friends who are ENT specialists, hey, I hardly see this 𝗙𝗊𝐶 in my. So there is, even within the race, there is some special predisposition that currently we don't really can put our finger on it. And what in our Singapore context, predominantly the Chinese are the race, the racial group of patients that we commonly see in Singapore for 𝗙𝗊𝐶. But I'm also aware that in Indonesia, like what Dr. Tan mentioned, there is certain belts within like Java or certain tribes in Medan, where I know there is a predisposition of this group of people developing 𝗙𝗊𝐶, and they are not Chinese, they are different race. So to answer that question, I think there's some studies looking at how the host, meaning the individual person, processes the virus, because we know from studies from how the virus got into the patient, and how there is a latent period before the patient finally developed cancer. And we believe there is some inherent differences among different groups of how they process the virus. And we know that the virus go into a phase called a latent phase, where it remain hidden in the patient's body. But over time, they can hijack some cellular machinery and try to drive the cancer into what we know as 𝗙𝗊𝐶s. So there are still many things we do not know, but I just want to stress, even within the same race, like Chinese, there are also differences. And also for certain areas where we know they are not typically developing particular cancer, but we still see some hotspots. Yeah, I think it probably relates to the immune system, or how individual relates to the so-called triggers by the virus infection.
I mean, these many of the viruses, and of course, for say liver cancer, I think the question of why, that's not quite clear. What we are looking at are observations where liver cancer is linked to hepatitis B, which is very common, of course, throughout Asia. For cervical cancer, this is throughout the world. And we recognize it's linked not only to cervical cancer, HPV, but also increasingly to head and neck cancers. And I think these are, the interaction there is really, these are interesting questions for both diagnostics and therapeutics. For diagnostics, it's more an opportunistic question. It's just a signal that is used to identify the cancer. But for therapeutics, we can truly take one step back and we look, the two companies that were trying to solve the viral problem and as well as the cancer problem, the names of these companies, we all know they are BioNTech and Moderna, right? So we can see those links between treating viruses and treating cancer. So this, research in these spaces can help society in unexpected ways as well. Yeah.
Thank you. I have a few more questions online, but before I do that, yes, Suzanne.
Thank you, Dr. Tan, and Dr. Lim, for your excellent presentation. I'm very excited for Lucence and the future for this company and for yourselves. My question, and something likely that the Head Foundation is very interested in, is then what? As in, what considerations do regional healthcare policy leaders need to factor in regarding health equity and access for cost?
Yeah. Firstly, I think that's a great question, and I guess for the last 3 years, we saw that in action where there was a combination of access to diagnostics, vaccines that really drove how different societies responded to the pandemic. And I guess if we look at cancer, the battle against cancer in the same way, we are going to see a very similar trend where access to the right diagnostics and therapeutics, these conversations are going to be driven by payers and having the right access at the correct price. So industry's role is to deliver these opportunities, these marvels, right, at the right price, and to develop and to scale it up so that this can be affordable to the wider range of the wider patient community as a whole. And it is truly the responsibility of payers to make sure that this is sustainable for industry so that the global society can benefit from this. Otherwise, there is no point having an invention if this is not accessible. So I think these conversations are going to center around value. They're going to center around access, and different societies will respond differently. And I guess this area will just grow, right? Because I think we want a world where no patient is left behind, but at the same time, everyone needs to play their part in this. And it's just going to be a very challenging environment where one step, some societies will take that step first before others. Yeah.
Well, I maybe just add on to what has been commended. I think it's not just detecting it. Then what's next? We also must have the downstream resources to be able to diagnose the cancer directly and then start treatment as soon as possible. Because I think for NPC is typically treated with radiotherapy. So I think access to treatment, so what if we were to detect a large number of patients much earlier, but the downstream, how do we follow up with, getting these patients who are diagnosed earlier to mainstream treatment is equally important. So I think it's a whole entire chain of not just diagnosis, but early treatment and follow up. Yeah.
Yeah, I think to that point, there's a point that was also being raised in one of the Q&As, and the point, as we move towards greater detection, does society have the infrastructure in place for the therapeutics that is necessary, right? If we pick up all these people with early stage cancer, the reason we are doing this and it's so beneficial is the likelihood of survival, the likelihood of treatment is very high. But do we have the infrastructure in place? The society, so maybe a little bit, pushing it a little bit in both your perspectives, in Singapore would adopt early detection as part of a health screening process. Do you think that the infrastructure is ready for the treatment that will be necessary with such a process?
I can probably speak on behalf of the NPC screening. I believe that if you can pick up NPC patients earlier, i.e. they are picked up as stage 1 rather than stage 3 or 4 when they come in with lymph nodes, certainly we know from medical data that their prognosis is certainly much higher. And Singapore infrastructure, I believe our colleagues, the regional oncologists, will be able to treat these patients quite expediently once we are diagnosed with NPCs. But I'm just alluding to my comment earlier is probably like scaling this up across Southeast Asia and Asia. Then, of course, the infrastructures of the relevant countries also need to be scaled up in that sense to be able to cope with this increase in resources.
Yeah, I completely agree. This I mean, healthcare is it's there are so many moving parts. Making sure that people have access is truly difficult. I guess we are seeing some of these challenges already in the even in the Singapore landscape, where most recently we have seen the cancer drug list as a an effort towards greater sustainability for healthcare financing. I'm sure the same conversations are happening throughout the region. What is the right trade-off? Because budgets may be limited, right? And but I think I look at it as it's truly important for the gaps to be made clear, because without having the gaps made clear, that there are X number of patients out there, that at least this is something which then public policy or private payers can come to grips with. Because what's the alternative, right? What's the alternative? Do we just leave those gaps unveiled, and undefined? And I just find that unsatisfactory as well. But I recognize the challenges behind, if we really are able to do early detection, and there are some societies that may find greater challenges in actually treating and managing this. So this is all true. Yeah.
I think I'll just quickly come to a couple of questions that I think are very important, and many of you in the audience might also be interested in this. Where can we get the test? When is it available? What's it called? How much does it cost?
Yeah, so I think these MCED tests are actually available in the United States. First, I want to say these are geographically available. In the United States, this is has been released at 940. I don't quote, it's around there, 940 something. It's online. Check the website. It's a USD price to the patient. These tests, MCED tests, will be available in Asia as well. I think the pricing and the performance, these have not been openly released yet, but they are going to be available as well. And I understand certainly, these are going to be something that can be beneficial to, these are where the conversations with the various payers, such as insurers, public payers, they will begin at that time.
Thank you. Thank you very much, Dr. I think many of our audience members, or what I can see on the online comments and questions, are keen to explore this as a possibility, even some saying that, should it be part of their annual medical checkup, which is a question that also has sort of raised, how frequent should we be thinking about MCD? Is this something that we should be doing it once every couple of years, or is there symptoms that, should be leading us to getting MCDs?
For many tests, the cancer screening tests, these are recommended anywhere between 1 to 3 years. There is no perfect test that will pick it up at all timings. I think these timings are driven based on two things. The ability to detect pre-cancer, such as a colonoscopy, which you don't need to do every year, as well as, of course, cost, because the frequency of these testing, when they are widely used, certainly a $1 test is very different from a $1,000 test, right? So I think these are good questions. There are many studies looking at these. I think the recommendations lie for such MCED tests right now lie anywhere between 1 to 2 year at a 1 to 2 year frequency. Yeah, so I hope that's an answer that is quite clear.
Those who asked this question on the online chat. There's another question here that was sort of raised. I think it has to do with the accuracy of the tests, and Lucence particularly, which you're aware of. But I know, of course, a lot of this is currently not public, not all of it is public information. But if you could share a bit, you did share about the challenges with mammograms, and despite many years and many advancements made in mammogram and its prevalence across societies, there are a lot of issues in terms of accuracy. So in terms of these multi-cancer tests, what is the accuracy level? Does it remain constant across the various cancers that are being tested?
Yeah, this is a very, very important point. What the types of accuracy we are seeing from these tests are best phrased in terms of false positives and false negatives, to better understand how they are going to be used in the real world. And your use of mammograms was exactly right, because we are looking at in mammograms at a test that has that out of 20 positives, only one actually has cancer. Now, what we are looking at for such tests is a performance quite similar to the rapid antigen testing in COVID-19. Now, when I use that example, it's firstly important to note that patients who use the test typically will not be given false positives. This is important because a false positive result is very, very scary to deal with. And you cannot eat, you cannot sleep. The moment that report comes in, your life flashes before your eyes, right? And this can affect you and your daily life for a long time until the issue is resolved. And no one wants these to burden the healthcare system if a false positive for colon cancer happens and that patient goes for an invasive procedure, which is negative. This is bad for the system, right? So the key thing first to recognize about these tests is that, false positive rates are very low. Just like how a rapid antigen test typically doesn't report false positives. Now, for the detection of a case when it is there, this is more between something like 60 to 70%, just like, the rapid antigen test. This does mean that some cancers may not be detected at a very small size, even if the signal is there. Now, it is important to put things in context here, which is that the alternative to these tests, just as, for example, for liver, for pancreas, for nasopharyngeal cancer, is that they won't be detected anyway, right? So 7 out of 10 is still a lot better than 0 out of 10. So this is the thinking around why these tests, but to communicate this, to bring it into the healthcare system, to best understand how to counsel a patient that these tests are in addition to your, routine care. This is an important part of physician education. So the concept is that 7 out of 10 is going to be a lot better than 0 out of 10 in the real world, and that patients should not be unduly worried by false positives. So I hope that that's a complicated way of explaining it, but every test will have its upside and downside. Yeah.
I think there's a question here. It's a bit more technical, and I, to be honest, don't really understand it very well. But I'll ask it. There are 2 questions here. One is, by the time a lump can be felt or detected, this audience member sort of made the assumption that it has been circulating in your body for some time, the cancer. So is there a way that we can sift it out earlier? And another question sort of asked, is there a way to detect cancers prior to tumor formation?
I'll take the second question first, which is there a way to detect cancer before? I don't think that's happened very much in blood. But certainly, the performance for such tests in blood is not very good for cancers before they are formed, the so-called pre-cancers or polyps. But certainly for invasive procedures, it's possible to pick up polyps before they are detected, before they turn cancerous. So that happens quite routinely on a colonoscopy. And that's actually why the recommendation isn't for colonoscopy isn't on a yearly basis. The idea is you get to, remove polyps before they become cancerous. For the first question, do we see signal even at the earlier stages? Yes, because these cells in a tumor, they are not static. They do turn over. And when they turn over, they release signal into the body where they can be detected in the blood.
Before I move to any more questions from the audience, before I move to a few more questions online. All right, I think we have a couple of questions here. I'm just scrolling to find the right questions here. I think you shared this in your presentation, Dr. Tan. In Western societies now, the rate of cancer is about 1:2. You just got to look in one direction and one of you is going to get cancer. In Asia, we're still fortunate enough that we have to look at both directions. Is this a function of something in Western society? Is it the age? Western society on average is a bit older than ours. Is this a function of the lived environment in Western societies? Or is it because of better testing, better detection, and better knowledge?
Yes, then.
I think the major driving force in frequency is still certainly aging. We are looking at a younger society for now in Asia and a much older age distribution. So it's to be expected that cancer is more common. And 1 in 2 is, of course, 1 in 2 lifetime risk is very, very high. Ascertainment, as you have correctly said, the availability of screening and testing, this is also much more widely available in Western societies that fund, especially where with systems which fund screening, especially in Europe, we do see a lot of ascertainment there. And yeah, I think these are the 2 major driving forces behind why cancer frequency is so much higher in the West than in the East.
Dr. Lim, any thoughts to add?
I think certainly in the West, they are more accessible to healthcare, perhaps. There are more opportunities to get symptoms tracked fairly early. So that I think that also contributed to earlier diagnosis and detection. I think indigenously, I think I'm not sure about some carcinogens exposure, but certainly smoking, in my view, smoking alcohol, chronic alcohol consumption, these are very well established carcinogens that is clearly evident, for head and neck cancers. So I think that I'm not sure whether that has been differences between Asia but US, but my sensing is probably quite similar.
Yeah.
Yeah.
Okay, we've got a couple of questions from our audience online. I see one that just popped up about DNA-based predictive cancer testing. Your thoughts?
Yeah, so so far everything we have talked about to date refers to cancer screening or tumor markers now, and to be repeated. I think the question DNA-based predictive screening refers to the testing of a lifetime future risk. And so that test is it's also a blood test. It will be, I think the best known example of this is Miss Angelina Jolie, who was diagnosed with breast cancer. She didn't, and she made a decision to go for a breast surgery to remove her breasts because she was told to have high risk of be at high risk of breast cancer. So I will say, these tests provide important life-changing information. They should be provided in a responsible way, because clearly, being told that all of us have very specific risks. I mean, these need to be conveyed in the right way. The outcomes, the treatments also should be communicated by medical professionals. I recognize today there is a debate whether this should be provided by a consumer-based service or a medical service. I come down firmly on the side of the medical service, because I see how serious the results can be and how they can change lives. But I recognize there is that the counter argument, which is always also about greater access to information. So I think these are important. These are all very useful, very important. How we learn to handle such information is really, on a scalable basis, is really a key challenge.
Anything you'd like to add, Dr. Lim, from your experience?
Probably nothing else
Okay.
to add on that. Yeah.
I think this question, I'll sort of paraphrase it a little bit, because sort of asking how confident in 10 years are you that in 10 years Singapore will make liquid biopsies standard as part of our health screening process. But I think more towards that sense is, do you see, societies like Singapore, how would you, if advocating to policymakers in terms of liquid biopsies and various other pre-cancer screenings, right? The Singaporean government has been very committed in trying to improve the average healthcare of our citizenry. We are very aware that we are an aging population, and we want to try to minimize the impact, especially the economic impact on society of an aging population. So how would you speak to policymakers about this? How would you convince them that liquid biopsies would help in this national conversation towards a healthier Singapore?
Yeah, so I think for any conversation with either a public or private payer, there's certainly a need to focus on a cost utility. It's really about, or if I may just simplify that, cost effectiveness of any intervention where we must balance the cost of a test or a drug and with the benefit it brings to the population. And I think that's really the conversation that needs to be made. For liquid biopsies in late-stage cancer patients, I would say today in the United States, where we are already approved, we have had those conversations. Liquid biopsies today are considered routine for patients with late-stage lung cancer. These conversations certainly will be different from country to country, but I look at a future where such tests are going to be so much more affordable that these conversations are just going to eventually become easier and easier. So in 10 years' time, I expect what we are discussing today to be maybe 10% of the price, right? So that's going to transform. It's going to transform how health screening is done. It's going to change how patients are cared for.
I think there's interestingly on that very similar point, right? There's a question that I guess to Dr. Lim's practice. One of our audience members is saying NPC is high in Singapore, but it's not part of the cancers that are routinely tested in the top 3 and subsidized. Should we be considering bringing NPC into the fold?
In terms of primary screening?
Primary screening.
Yeah, so I think if you look at the SMC, I think the SMA website, there is a like a common cancers that we advocate screening, and that's not just my opinion, it's just the whole fraternity's opinion. I think for MP, certainly there was a consensus that screening of high-risk individuals would constitute something that we should consider seriously. And what we meant by high risk will be family histories, first-degree family history members who had an index patient who had MPC. So although MPC is not genetically transmitted like a mutant gene that is passed on from one generation to another, but however, we do see there is a higher risk for a first-degree relative to develop MPC compared to a normal population. So in that sense, I think we are enriching the population that we are more likely to pick up more index cases or MPC. And I think this should probably be the strategy that how we advocate, rather than rolling this out as a community screening for every single patient, but rather for somebody who has an index patient who had MPC. I think that there is some evidence, both not just in terms of for screening. I believe there was also a recent publication done by the NCI, which is a US-based, where they look at the cost effectiveness for screening. And I'm not health economics, but they look at the number of quality years from that screening process, and they do find that to be cost effective for first-degree family members.
Okay. Anything you'd like to add, Dr. Tan, on the MPC front?
No, I think it's I think it's a conversation that the clinical fraternity, it's an ongoing conversation between the fraternity and the regulators, and I think that conversation should continue. I think the evidence is there, and at some point, it's going to make sense for a larger group of people than today. Yeah.
I think a question that was asked, and I may have missed this out, how many, if you're aware of this figure, liquid biopsy tests have been done, commercial liquid biopsy tests?
I think this is going to be different from country to country. This is most advanced in the United States, where it is a routine part of cancer care. So we are talking about hundreds of thousands of patients with cancer in the United States. And I'm not so familiar with how the MCD tests have done, but I would expect that, it is a big pain point for people to be screened for cancer effectively. Yeah.
Okay, ladies and gentlemen, I'm also very cognizant of time. A very kind colleague has flashed a number in front of me, and the number has gotten very small. So we have very little time left, ladies and gentlemen, but before we close the session, if there are any questions from our audience members in the room, before we invite our two, Dr. Tan and Professor Lim, who has very kindly agreed to join us on stage today to share some of their closing thoughts. Do you have any questions from the room, or anyone who would like to And any perspectives?
Hi, sorry, I
Yeah.
have a question. So thank you very much for the talk. I really enjoyed it, and I think the developments are very exciting. As someone who, I mean, I hope I don't have cancer, but there are people in my family who has had that. I think this is really exciting. Just wondering if there are any potential drawbacks or bioethical issues that might be associated with MCEDs.
It's a great question because such testing does focus on, it does focus very much on DNA-based testing. I'll say first that this testing is focused on many cancer signals rather than the signals, say for example, of hereditary genes, or so that allows for a greater targeting of such testing. I would say if there was a number one problem here, it's really the question of access and equity. We are looking at tests that still remain, even at $950 USD, these still remain unaffordable to the broadest range of society. I guess these are things that we certainly hope that time and scale will help to bring down for society. Yeah.
Any comments on MC?
No, the MC doesn't have any more comments, but the MC would like to take the opportunity, fully aware of time, to thank our two speakers. But before I close, do you have any closing remarks from Professor Lim and later from Dr. Tan?
All right, I would say that with technology, like what Dr. Tan mentioned, I think the PCR equipment that typically runs all this sequencing has gone so much, particularly during COVID. Now, I think a lot of countries are familiar with the PCR technologies, and hopefully that will bring more equity, and some of this technology can even be transferred to the indigenous countries to develop their, do their own testing. But I also don't want to forget the larger thing is also healthy lifestyle is equally important. I mean, we just can't rely on this screening assays to expect things to change, because in my field, smoking still remains a big problem. Alcohol consumption, these are all well-known carcinogens. And I think broader scope in terms of how to bring down some of the known carcinogens will be equally important. And finally, I think vaccination. There are very successful stories for vaccinations against certain cancers, particularly, cervical cancers that is driven by HPV. And now we do have HPV vaccination, and remarkably, certain countries that adopted vaccination have seen a dramatic drop in the cervical cancer. So I think there are just little pieces that, hopefully we can all encompass the more holistic approach for screening. Yeah.
Thank you very much. Dr. Tan, your closing thoughts.
No, I'm good. I've certainly spent a lot of my life on this topic. I'm passionate about it. I do think, and we were talking just outside, just before this meeting, that 5 years ago, if we were told that we could buy a diagnostic ourselves at the Guardian Pharmacy, bring it home and use it, and it would be affordable, I think all of us would have gone like, get real, right? But after COVID, it's normal. It's routine. The boss says, "Why are you on MC? Send me a picture of your COVID test." And I think those conversations and change happen every day. When I started Lucence in 2017, 5%, only 5% of medical oncologists believed in liquid biopsy for late-stage cancer. Today, it is 95%. So the change can happen when technology becomes affordable, and omnipresent. And I think it's so important that, this doesn't happen just by doctors. It happens together with payers, with regulators, and it happens with industry. So I believe such testing that we are talking about today, it's a nascent thing, but it's going to change society in the next 5 years. Yeah. So I hope, this is a great conversation to have. I really enjoyed this because there's a lot for me to think about in all the questions you have asked as well.
Thank you very much, Dr. Tan. I really enjoyed the dialogue and learning from both of you. And I was very happy until the last 2 minutes, because that was going to be my closing line. right? If you told any of us, because we had this conversation that we have to test ourselves, but who knows? Who knows what the world is going to bring? You know, as Dr. Tan had shared, we never would have thought that we could test ourselves. And yet we're also routinely doing it. I just did it a day ago. So we're so used to it. Who knows? Maybe one day we'll be able to even test for certain cancer markers ourselves. But today, ladies and gentlemen, I think as Professor Lim has shared, we have to continue living a healthy lifestyle. The tests are going to detect when something is wrong. But let's do our best to also minimize the possibility of that happening. And when it does, hopefully access and equitable access to tests and to detection that will allow us to seek quality treatment will be made available to everyone. Ladies and gentlemen, thank you very much for joining us this evening for our THF Dialogue. And I'd like to take this opportunity again to thank our distinguished speaker, Dr. Tan Min Han, and Dr. Lim, Professor Lim, for joining us as a discussant in today's conversation. Ladies and gentlemen, thank you very much for joining us on the THF Dialogues. Do check our website. We have an upcoming interesting event about meritocracy, education and equity in Singapore, something that our president just spoke about a few days ago in Parliament. Check it out. It's on 29 April. I know it's a Saturday. I too, unfortunately, have to work then. But do join us, ladies and gentlemen, and hopefully it'll be an opportunity to join in another exciting conversation to broaden our perspectives and work towards improving the education and healthcare opportunities for everyone in Asia. So thank you very much and good evening.